hepatobiliary specific contrast for this. Now, the key point for FRCR is hypervascular lesions. When I use the word hypervascular means these are the lesions which enhance on arterial phase. So on the left is the benign list and on the right is the malignant list. And FNH adenoma hemangioma. Hemangioma has got slightly different. This hypervascular hemangioma will be a small, we call it a flash hemangioma. But it can show restricted diffusion. It has got its own characteristics. But today I'm going to teach you the difference between FNH and adenoma just on the basis of hepatobiliary specific contrast. Malignant, on the other hand, HCC or mass-forming cholangiocarcinomas, but there are huge hypervascular metastases, which are these. And this is an exam case. Take a screenshot of this because this is what they will ask in the exam. What kind of metastasis can be hypervascular? The list is more than what I have shown you here, but at least try to go through this. Now, if you see here, we have got this is a non-enhanced CT, this is an arterial, there is a lesion here which does not show washout. Does not show washout is taken as a good sign, but going back to the main concepts of phases of contrast, arterial phase in liver, don't confuse it with arterial of angiogram. It should be slightly delayed than this. So it should be about 35-second delay. Portal venous phase is 70-second, and then there is an equilibrium phase. Equilibrium phase goes from 3 to 10 minutes. And on a CT, you cannot utilize it because you will have to scan patient in multiple phases, giving so much radiation. But on MR, we utilize this. Key concept to remember is that a benign lesion does not show washout. So if arterially enhancing lesion is there and it does not show washout it is a good sign. It means that the lesion is benign. Some people actually confuse the concept of washout. They start looking at the lesion and start asking themselves, has it become darker or whatever. Don't do that. Try to just see it vis-a-vis the surrounding liver parenchyma. Even if it is iso-intense to the parenchyma, means there is no washout. But if it becomes black, it becomes darker than the parenchyma, means washout. Look at this case, which is arterially enhancing. Here, one can argue that there might be a bit of a washout, but in a slightly delayed phase, complete washout. So this was metastasis. This is characteristic of a malignant lesion. So please remember that these principles which I have defined, you can take it with a pinch of salt because some of the lesions, particularly adenomas, fibrolamellar HCCs, cholangios, HCC, etc., there can be pitfalls. But overall, this is a very good, tool to initially diagnose it because there will be other features which can be picked up to differentiate between them. In contrast ultrasound, Prof. Cosgrove, he coined this phrase of black is bad. On contrast ultrasound, the whole of the liver is enhancing, and if you see something which is black, darker, then that is bad. Now, this concept is my main aim for you to remember for your exam. And in the exam now, they have asked and they can ask hepatobiliary specific contrast. Many of you who are listening from overseas, I know you don't do it. It's very expensive. And very few departments in many, but in the exam they can ask. So you should have a clear-cut concept about it. And the case which I selected today was a classical example. I have not shown you a hepatobiliary specific there, but because that was done in London, and this patient had a had a then resection also. But the key concept is that two types of contrast can be used in liver imaging. One is classical, gadolinium. Whatever your department is using, we call it extracellular agent, ECA. Then there is another one which is known as hepatocyte specific agent. So we'll use the word HSA. Now, these are there are two in the world, and I will not, the one which is produced by Bracco, which this is the generic name. It is known as multi-hans. We don't use it in UK. We use this one, and we call it Primovist. In USA, it is known as Eovist, Bayer. And the pharmacokinetics is key point to remember. This is the key point and key concept to remember. Look at this. 50% excreted through liver. 50% of it is excreted through liver. And how will it excrete through the liver? Through the hepatocytes. So it will go into the bile, and it gives you a sort of an MRCP also, which is not a very good quality, but we utilize it for at times for leaks, etc. And so whenever there are normal hepatic cells, it will be either isointense or it will be hyperintense. FNH by definition is not a neoplasia. It is a vascular malformation, and means it is an hyperplastic response to vascular malformation. So uh, that will have normal hepatocytes. So the technique which is done is, first of all, this is quite expensive. You see 115 pounds per bottle versus 9 pounds per bottle for the other agent. Uh, there is a special 20-minute delay phase. Look at this. This is our protocol in our department when we use gadolinium, where we use various kinds of T2 sequences, T2, and then this is a highly T2 weighted sequence, one coronal, two axials. Then we do a T1, then in an opposed phase to look for any fatty change. Then we do DWI. Highest B value which we are using is B 1200. Other departments might be using other highest B value. And then we use an auto injector. We do a pre-contrast fat saturated T1, then do a auto injector arterial phase, venous phase, 3-minute delay, 5-minute delay, 10-minute delay. This is our protocol with normal gadolinium. When we are using hepatocyte specific, the key point for you to remember is we have to do a 20-minute delay. In 20 minutes, it excretes through the hepatocytes. And this is also an example of FNH. This is a very, very good imaging tool, 96 to 100% specificity for FNH, and can differentiate FNH and adenoma. So this is one example where in your FRCR exam, the examiners can ask you, but they can ask you in other scenarios also. I will tell you, this is so forget about the scar, etc. There is a scar, but I just want to show you that this is the venous phase and this is the hepatobiliary phase in an FNH. This example from literature is similar to the case which I showed you. Here, what is happening that there is an arterially enhancing lesion with a bit of scar, and in delayed phases, still there is no washout, so this is benign. And then in hepatobiliary specific phase, you can see that because the adenoma hasn't got normal hepatocytes, there is no contrast there and it has become black. So this is the scenario which will come in your exam. In our clinical practice, now we are using hepatobiliary specific contrast more and more as a problem-solving tool in cirrhotic nodules to diagnose early HCC, and we are also using it in colorectal metastasis, which is common sense. In colorectal metastasis, you know that when a patient presents with presents with carcinoma colon, and even if the patient has got metastasis in the liver, they remove the segment, and so they require a black and white answer. How many metastases are there? And still the patient remains a surgical patient. So in that type of scenario, it's a very good imaging tool as a problem-solving tool, both for HCC, and it's common sense. Metastasis will not have normal hepatocytes, so it will appear as black. This is an example of an FNH, and you can see arterially enhancing does not lose contrast, and then it retains contrast on hepatobiliary phase. So that was the aim of this one. This is a good example from literature. I've got a similar case which I could not find today to show you. This initially on a CT scan, this patient was reported as metastasis because the patient had breast carcinoma. But when they used hepatobiliary contrast, they could see arterially enhancing lesions which retained contrast on hepatobiliary. So these were multiple FNH. So it's a black and white difference which this can make. Okay, we go to the next case.
Okay.
Oh, just one point. Now, these days we are doing a lot of learning from mistakes type of thing. And in this patient, there is a learning from mistakes case also. And actually, what happened was that this patient also had a pelvic MR, and this was preceding the CT scan, by the way. And if you look carefully, because they have done a T2 weighted sequence, and this is missed. Now you can see, it is there. You can see the stomach, and there is a lesion, and it was simply missed because the interest was in the pelvis, and this was not seen. This becomes an edge of the film, a very good case. So I can show you in a 2B context, just as this scenario also. And this is a real life mistake which had happened. Luckily, it did not cause any issues. So it's quite a struggle to, this potpourri, to do a bit of teaching and then to show cases because of the time factor. So let me slightly modify my technique, otherwise it will run too late. So candidate 2,
Yes.
I'm going to ask you leading questions on this one. This patient has history of breast cancer. She is 66-year-old female. Since last 2 years, she has been stable. Now she presented to the ophthalmologist with ptosis and third nerve palsy type of symptoms. There were also some signs of sixth nerve palsy and some headache. So they asked for an MR. My question to you, what kind of technique will you use for the MR in this scenario?
So I guess I would initially ask for an MRI head with contrast, but given that
Okay.
there is...
Yeah, that was my question. You must use with contrast because the patient, basically the patient has got known malignancy or a past history, and the point is that we must do with contrast. Having said that, let me take over, and then I'll ask you leading questions. Now, if you see, this is a T2 fat saturated sequence, two globes are there. You can see the optic nerves right and left. You can see the CSF around the optic nerves. You can trace the optic nerves to the the apex. We can see it goes to the optic chiasma. The pituitary gland is here. You can see the cavernous sinus, and you don't see much here. Now, I am going to show you a post-contrast sequence. Now, on post-contrast sequence, just look at the same anatomy, and I'm going to scroll for you. Anything?
Nothing jumping out. The
Nothing.
optic nerve.
Okay.
The optic
So,
nerve.
so what I'll do is I'll give you an axia. Now take over. Take over the mouse.
Okay.
Yes, please.
Okay, fine. So looking at this post-contrast axial slices, I'm just going to scroll, focusing on the orbits. So the left optic nerve.
Okay, let me give you a hint. Look outside the optic pathway and the orbits.
So looking on the left side predominantly.
Look at the brain parenchyma.
Sorry, it's really jumping, unfortunately. Do you mind if you scroll for me? Just
Yeah, I'm going to scroll. So I've gone to the level of the medulla. I'm coming superiorly. Slightly, maybe I should shift it slightly anteriorly. Anything on this slice?
so I'm looking at the extradural spaces, given that this patient's got breast cancer. So I can see some irregular leptomeningeal enhancement of the cerebrum, or cerebellum,
Excellent.
shall I say.
So what do you think is happening?
So this is a carcinomatosis.
Okay, good. I will take over, but
carcinomatosis.
before I take over, what is this?
Looks like the pituitary seems to be arising from the pituitary. So I don't think it's the. I'll tell you, it's the. Yeah, pituitary. Is it the stalk of the pituitary?
How do you explain this finding then, if it is the stalk?
Bitemporal hemianopia, but that doesn't make sense because it's not large enough to cause compression of the optic nerve. Yeah, not sure, to be honest.
Okay, we stop there and let me take over. So this is leptomeningeal carcinomatosis. I'll go through the case in a minute. Let me go through a few teaching points. Now, high signal on a flare sequence, in this particular case, because it was an orbit type of protocol, they did not do a flare brain. I'm sure there would have been some high signal on the flare. And this is what, when an examiner shows you in the exam, they will show you a flare sequence. So there is a differential diagnosis in Chapman, sulcal flare hyperintensities. Develop your eyes on this. Subarachnoid hemorrhage and because please remember leptomeningeal enhancement can also happen in other conditions like meningitis and leptomeningeal carcinomatosis, etc. This is a very, very important case for the exam. So what will happen usually is that they will show you a flare sequence. Now, this is a flare sequence where you can see that there is high signal. And when you see high signal like this, the next thing is ask for a contrast. And this is what they are expecting. If it enhances, it is a different scenario. If it does not enhance, it's a different scenario. Why? Because in this particular case, if you see here, the foliar enhancing, these things are sorry, this is the flare. And then we gave contrast and these foliar enhancing. So this is a leptomeningeal carcinomatosis in a case of esophageal carcinoma. On the other hand, look at this one. This is a case of subarachnoid hemorrhage. If you see the sulcus here, where I'm pointing out, there is high signal on flare. Please remember that usually the sulcus has to be low signal. And then on CT, this was 6 days old subarachnoid, so it was not visible. You give contrast, it will not enhance. So the key point is that it's a very important differential, and you have to really uh, develop your eyes on it. And I show many cases in this regard. This is one of the favorites in the exam. Now, let me tell you the findings here. And so the eye see what the mind knows, and if uh, you don't see it, you will miss it. Now, if you see here, look at this midbrain, and it's a beautiful finding. Look, there is enhancement around the midbrain. Usually you should not see it, and this should have been picked up. And then there is enhancement around the pons. And then we can see these folia, which are enhancing. If you go down, maybe one can argue that even in front of the medulla, there is a bit of enhancement. Please remember that the patient had oculomotor nerve palsy, bilateral. Now, here, if you see, this is the midbrain. Do you see this is pons? From the midbrain, which nerve comes anteriorly? This is oculomotor. Please remember the trochlear also comes and it goes around the midbrain and comes anteriorly. So this is showing enhancement. And of course, because of time factor, I did not show you. And on the other hand, you can see that the other sided nerve, it is also showing just at the root entry zone where it is touching the midbrain. So then coming back to infundibulum. Now, this is the pituitary gland. And then as we go superiorly, this is infundibulum, and which is thickened and which is enhancing. And please remember, now, of course, we will be able to see it on this one also. Here it is slightly thickened where I'm pointing out. Please remember that the differential diagnosis of stalk lesions or infundibular lesions, metastasis as well as lymphoma is up there. Metastasis is maybe the most common cause of stalk lesions. So this is what it was. Okay, candidate 2, thank you very much.
Thank you.
Now, candidate 1, let me see. Yeah, candidate 1 is here. Candidate 1, are you here? Let me make you a co-host. Candidate 1, are you with us?
Yes, sir, I'm here.
Okay. So your first case, I will slightly modify my technique because this is a very, very challenging way, potpourri. And because of the teaching factor, I think I will not take a classical Viva, but I will uh, show you according to what is possible considering the time factor. Now, what happened was this patient is a 49-year-old, lower limb weakness and sensory symptoms gradually for the last 2 years. MR lumbar was initially done, which was normal. Now the clinicians, they have asked for MR cervical and thoracic spine, so they wanted a whole spine. So I'm showing you a T2 weighted sagittal sequence. I am going to scroll through it, and I'll just ask you a leading question on this one. Any gross abnormality, candidate one?
I can appreciate that there are degenerative changes seen within the cervical spine. Other than that, there's an extra-axial altered MR signal intensity area seen anterior to the spinal cord. That is low on T1, T2. And within this cord as well, there is a hyper intense signal noted that is traveling within the cervical as well as the thoracic cord.
Right. So as far as your second finding, the first finding is concerned, is my mouse
Yes.
visible to you?
Yes, it is, sir.
So this thing, what can it be where I'm pointing out?
So it is low on T2.
So I'm showing you at the same level. I'm showing you axial. Now, are you worried about anything? Just look at the CSF space, nothing else.
Okay.
So basically, that is artifact, right?
Okay. Yes.
Now, we come here. Over to you. Now, can you take the mouse control from me? Do you know how to ask for mouse? Candidate 2, can you tell candidate 1 how to ask for mouse?
Sure. On the top of the screen, you should see an option called View Options.
Okay.
And if you click down the drop-down list, then there'll be an option to say Request Remote Control.
The view one, yes. No, it's not coming over here. The view option is here, but ask for remote control is not here.
Okay, let me then scroll for you. Now, I'm showing you a sagittal T2.
Okay, so I can see some prominent flow void areas along the anterior and the posterior aspect of the cord. So I would like to review if there are any post-contrast images available, because they seem to be likely vascular in a region. Okay.
This is post-contrast.
Okay, so now they're avidly enhancing. These are likely vascular channels that are along the anterior and the posterior aspect of the spinal cord. So, and they're they're in the, they're extramedullary intradural. So, this could be an arteriovenous fistula, AV fistula.
So this AV fistula, where will it be based? Anatomy-wise.
It's extramedullary and intradural. And it's basically it's an intradural.
right? So now, if I go back to your T2, which was this one, what do you think is happening to the cord signal?
There is a normal T2 hyperintense signal within the cord as well.
So how can you explain that?
There could be associated myelopathy going on because of this fistula.
Which kind of myelopathy?
It's likely secondary to ischemic changes because there could be vascular compromise.
What kind of vascular compromise?
Like it's a fistula, so it's taking the normal supply from the cord away. So because of that, there would be reduced supply to the cord and causing the ischemic changes that are.
Right. What will you do next?
I would refer the patient to the neurosurgeon for the treatment because the cord needs to be. This something needs to be done about it, otherwise it would lead to further
So
neurological.
what will they do?
They will likely, or intervention radiologists can also embolize it, or coiling can be done.
Okay, thank you. Let me go through a few slides, and then I will show you the findings. So, this is dural AV fistula. Dural AV fistula. Look at the word, dural AV fistula. Now, the concept is very important because the Viva questions, as I asked you, are all regarding that concept. So, as the name tells you, this is the type 1 fistula. There are, I think, 5 types of fistulas. This one is very important for your FRCR. It has come in the exam quite a few times. Why it has come? Because you can pick it up. And I have seen young patients also. Usually these patients are, usually 50 to 60 is the most common age. But I have seen cases of 29-year-old. And they were suffering like anything. And you have to develop your eyes to pick it up on your normal reporting. So that is why it is an exam case. The concept is that there is a fistula at the level of the dura, and dural AV fistula means the arteriovenous fistula. So what is happening is that there is, because of this, high pressure coming into the veins. Now, these veins are also indirectly coming from the cord, from the pia mater or the pile surface of the cord. And because of the high pressure, there is a back pressure. So there will be distended veins. We call it venous congestion. Whenever there is venous congestion, there will be what? Venous edema. And that is why there will be increase in cord signal. And so this kind of myelopathy can occur because of venous congestion. So that is the concept. And now, let me show you another case, which is this one. You have to develop your eyes on the surface of the cord, just like candidate 1 did very well. She picked up, but that case was easier, and this is slightly more difficult because it is not as emphatic as the one which I showed you today. You can see this, we call it serrated outline of the cord. And with that, you can see that there is high signal within the cord. So this is another example. From StatDX, this is, I think, my own case, and this is from StatDX. Again, another one where you can see high signal, and then there is on contrast with fat saturation, we can see this vessels which are quite prominent. Now, let's go through the findings on the case. So, Uh, so these findings were well picked up. We can see these flow voids anteriorly giving that because they are sitting on the pia mater, on the pile surface of the cord. And you can see that the signal intensity is also high. And of course, it all depends on the examiner and the scenario. If they want to show you a T2, they can. If just like the candidate asked, that was a very good call to ask for post contrast, and you can see these serpentine vessels. And on axial, I can actually just to check you, show you the axial instead of the sagittal. Even here, you should not be seeing these prominent vessels, anteriorly and posteriorly. Even on an axial, you can see, and you can imagine that, part of the fistula might be sitting here, and these are very prominent veins. Okay, well done, candidate one. Next case. Now, uh, this case, let me tell you the scenario. This is a 79-year-old patient had cholecystectomy about 1 month ago. Since that is having fever off and on, and then now has developed right chest pain, fever. X-ray was done. There was effusion on the right side. With that, the respiratory consultants, they have asked for a CT. So I'm showing you a CT. Over to you.
So I'm provided with the CCT chest. Sir, I don't have the control to scroll.
Okay, and please remember now, candidates, whoever becomes a volunteer, you have to learn before and ask your colleagues how to ask for mouse. Now I'm showing you. Just concentrate on the right side of the chest.
So I can appreciate that there's a hypodense cyst on the right kidney, and there are still cholecystectomy sutures are noted in place. And as I'm going above, hypodenses are also seen in the left kidney.
I'll quickly show
Okay,
you
so
the.
there's actually there's herniation of. I can see that the abdominal contents are.
So I'm not interested there. That's a long-standing
Okay.
finding. Don't worry
Okay.
on. Just concentrate on the right side.
Okay. So I can appreciate that there is a thickening of the pleura noted along the posterior segment of the right lower lobe with adjacent atelectasis, and there is also a thick walled area noted, and some calcified plaques are also noted over here, and this is all in this subphrenic region. I would like to, in my routine practice, I would also like to review it on the lung window.
So I've shown you the lung window. There is a bit of consolidation. I'm not interested more than that.
Okay. So this is likely an infective etiology. And as the pleura is also thickened with the split pleura sign, there's an underlying empyema, and make out this component with the calcification.
Do you want to see any other plane?
Yes, I would like to review the coronal images if available.
Okay, so I'll show you coronal. So I'm going in one direction and then I'll come back. So I've gone anteriorly. Now I'm coming back. I'm going backwards.
So there are these hyperdense foci noted along the superior aspect of the liver, and with surrounding hypodensity noted along it. And there is also associate that is likely, I think, the cause of the surrounding inflammatory and disunderstanding that is going on. So as there's recent history of cholecystectomy, this could be either, I cannot appreciate any definite mortal lucencies around this. So in my differential, it could be a case of um, gossipy pyboma, or in the second, I would also like to keep the dropped gallstones while the surgery was taking place. That has caused this adjacent inflammatory change in the subphrenic region, as well as the right-sided empyema that is seen. And I would urgently convey my findings to the referring physician.
Okay, thank you. Uh, so the candidate did mention two differential, and the candidate was uh, uh, story means story. So this was post cholecystectomy to about 1 month ago, spilled gallbladder stone with abscess formation. And I've seen cases of spilled gallbladder stones. They sit there for 1 year, and patient presents with one of the patients which I saw in my clinical practice. It developed a soft tissue abscess, which was clinically very challenging, and it ultimately it got reported as a possible sarcoma, and we sent the patient to RNOH. And actually, what was happening that this is what happens now. This is a very classical example of a story case. So what is happening that there is a metal clip here, and if I go to bone density, you can see a metal clip here. Now, then another metal clip here. And if you see with these two metal clips, this one is not metal. There is a stone sitting here. They are spilled. And then look at these ones. There is nothing else in the world which can explain this. How many of them are there? Just think as if the gallbladder is sitting here. And they have caused this chronic inflammation. And this inflammation has gone into the chest. Simple as that. And initially on this CT, actually the diagnosis was not made. And then after 8 days or so, another scan was done, in which the abscess has increased in size. And even then, I believe we said that this is it, but we could not initially think of the exact cause. An MR was also done, and on MR, of course, there was an abscess here, and I just want to show you a post contrast. You can see enhancement, and on a DWI sequence, which is this one, you can see that the pus, how bright is the pus. So this was an abscess. Okay, good, well done. Story case. Candidate 1. This is your last case. This is a 61-year-old with history of previous history of lymphoma, but apparently the patient has been treated for lymphoma. So there is a previous history. Patient has presented with diplopia, facial tingling, headache. So I'm showing you a flare sequence. Should I scroll for you?
Yes, please.
Okay, so
I don't know. It's the option I usually do know how to take control, but somehow it's not coming today.
don't
Sorry
worry, don't worry.
for the inconvenience.
So I have gone to the vertex. I'm coming down. Keep looking.
You can appreciate few periventricular white matter hyperintensive foci. Other than that, I can appreciate that there is a abnormal signal intensity area noted in the region of the in the cellar and supracellular region, and there's abnormal signal intensity areas also noted in the infratemporal fossa on the left side that are also causing abnormal signals in the pterygoid muscles, the medial and the lateral pterygoids that are involved. And the pterygopalatine fossa and the foramen are
Right.
also involved.
Which sequence would you like to see next?
I would
If
like to
there
see
is
the
choice of only one more sequence,
coronal post-contrast if it's available.
coronal post-contrast. So I'm showing you a axial post-contrast. So I'm coming from top.
Okay, so the infundibulum and the hypothalamic and the pituitary stalk is also enhancing, and there is also enhancement along the Meckel's cave on the left side, and with thickening, and this is also extending inferiorly into the, as I've mentioned before, into the left infratemporal fossa, and involving both the medial and the lateral pterygoid muscle, and it is also extending into the nasopharynx. As the patient was previously, patient is a known case of treated lymphoma. This could be a lymphomatous deposit that has undergone a perineural spread via the trigeminal nerve, I think, as it is involving
I'm
the
showing you a coronal now.
Okay. Okay, so from here, I can appreciate that the lesion is traveling from the infratemporal fossa intracranially, and I think via foramen. So I think it is likely foramen ovale, the trigeminal, the V3. It is traveling via the V3 into the Meckel's cave as well, and it is also involving the pituitary stalk and the infundibulum and the hypothalamus as well.
So that is direct involvement or not direct involvement?
I think it's a direct involvement. It is going through it's a perineural spread via the nerve into the intracranial cavity.
Okay, thank you. So case 6 is, I'll go through the case later on, but this is a masticated space lymphoma with perineural spread and infundibular involvement. Now, infundibular involvement is not direct involvement, and lymphomas can do it. It's what I want to tell you is that it was not contagious, as in The tumor, it went into the cavernous sinus. It didn't, to go into the infundibulum, then it has to go into the pituitary parenchyma and then go upwards. That was not the scenario. Another thing is, don't use the word infratemporal fossa. These are old terminologies. You have to use new terminologies. And this is what we call the masticator space. You were using the word pterygoids, which was fine. And please remember that this is masticator space. So idea of this case is that, first of all, this was edge of the film case, where the candidate did very well, where picked up the finding because there was something happening in the infundibulum, and then picked up this finding in the masticator space on left side. On the left side, it was different signal, and this becomes an edge of the film case, telling you that how important your protocol is. It was only visible in the last 2 or 3 sections. And so one idea is that you must have a robust viewing protocol, and pituitary fossa is something but extracranial, base of skull, orbit, paranasal sinuses, head and neck spaces, cervical spine, or whatever sequence you are given in the exam. It's favorite for the examiners to show you axial, because on a coronal or a sagittal, lot of anatomy is visible. On axial, it is slightly more difficult. So that was one thing. Now, if we revise the neck, head and neck spaces, the neck is divided into suprahyoid neck and the infrahyoid neck. Infrahyoid neck has got 5 spaces: visceral, carotid, retropharyngeal, perivertebral, posterior cervical. And the suprahyoid has got 8 spaces. The one which are in green actually go from the infrahyoid to the suprahyoid, and these ones are different. Look at these words: and parapharyngeal mucosal space, parapharyngeal masticator space, and parotid space. Now, this is the masticator space. And this masticator space, this is the parotid space, this is the carotid space, etc., etc. Now, so these are the contents of the masticator space, which include lateral pterygoid, medial pterygoid, masseter, temporalis, inferior alveolar nerve, and ramus, and body of mandible. And it's very important for the exam, extremely important for the exam. Now, view from downside, and this diagrams tells you that what are the spaces which are touching the base of the skull. What does it tell you? That pathology which is sitting below can go into the intracranial cavity. One of them is masticator space. And so that is why it was known as infratemporal, but now use the word masticator space. This is foramen ovale. This is foramen spinosum. Now, this is the parotid space which goes into the stylomastoid foramen. Of course, the carotid canal and the jugular foramen is there. Now, perineural extension of tumors from the masticator space is a known phenomena. So in your Chapman, it is given from masticator space to foramen ovale to Meckel's cave. Look at this non-Hodgkin lymphoma, and this is what our case was. And this diagram also tells you on a coronal that what will happen, that this is the mandibular division, and through which it goes into the cavernous sinus. So the trigeminal nerve has got 3 divisions. V1 and V2 go into the cavernous sinus. V2 then goes into the foramen rotundum, but V3 goes down, and this is foramen ovale. And look at this example, and this per se is a very good exam case, where you can see that there is a bit of high signal on the flare here in the masticator space compared to this. On post contrast, you can, even on pre-contrast, you can see there is soft tissue here. So what is happening, that there is actually a schwannoma in this case. You can see this schwannoma, and you can see because it is long-standing, it is causing expansion of the foramen ovale, and it is extending to the cavernous sinus. So on the CT scan, and this per se is an exam case, on a CT scan, you pick up this thing, and on a bone window, you can see that this is the foramen ovale. This is the foramen ovale, and you can see how expanded it is. So this is the concept of perineural spread. So in fundibulum, it's known, I have shown you another case also today, that metastasis can go directly to the infundibulum, and then lymphoma can also do that. And this was also visible on this case. So this was a lymphoma with perineural spread. Well done, candidate uh, 1. And I'll go through the case. And I think this was your last case. So on initially, I showed you a flare sequence. And on flare, the key finding, which was well picked up by the candidate, is that this is the midbrain. Anterior to the midbrain, this is suprasellar cistern. This is extra what we call tissue sitting there. Something is wrong. And then if you go down, and you can see that the stalk is thickened. And now it's a difficult one, but if you compare this side and this side, you can see that something is sitting there in the cavernous sinus. And then as we go down, you can see that in the masticator space, there is high signal versus this. And then when we give contrast, ideally it should have been a fat saturated, but because it was a brain study, it was not a head and neck or base of skull study, it was without contrast. So this is that infundibulum which has caused enhancement, and this is the cavernous sinus, and then whole of it is enhancing. You don't see it very well because it's not a fat saturated sequence. And the same finding on a coronal, you can see it here. Compare this with this, and you can see that it is enhancing. And then you can see it here that it is going through the foramen ovale. It is going into the cavernous sinus. Similarly, squamous cell carcinomas, etc., can also do that. Well done, candidate 1. We go to candidate 3. Candidate 3, are you with us?
Yes, sir.
Candidate 3, we have got a case which is taking its time to come on the screen. It's a spine case. Let the image be there, then I will. Okay. So here, this is 65 years old, Cushing syndrome, increasing pain and weakness, lower limbs, paresthesia. They've asked degenerative disc disease, question mark, spinal stenosis, question mark. Over to you.
Okay. So, sir, I'm provided with the sagittal section of MRI T2 weighted images, and in which I can appreciate that that there are ultra MR signal intensity areas which are noted.
Can you ask for mouse?
Yes, sir, I can.
Please ask for mouse.
Sir, I have requested it.
Yeah.
Okay. So, I'm scrolling through the images, and I can appreciate that there are ultra MR signal intensities noted opposite to the level of L2, L3, and L4 vertebral bodies, and they are also related to the conus of the spinal cord, and at places the conus cannot be appreciated from these ultra signal intensity areas, and which they are appearing ISO to low upon T2 weighted images, and degenerative changes are noted in the rest of the spine. So I would like to see them on post-contrast images to look for any enhancement.
So basically, what you have described, what do you think is happening?
Sir, there is something sitting which is intradural, and it is related to the conus of the cord.
So where is the cauda equina? You know, the nerve roots. Where are they?
Sir,
The nerve roots.
so this is the conus, and then the nerve roots I cannot appreciate. They are likely.
Are the nerve roots normal?
No, sir, they are not.
And what is not abnormal in them?
So I would like to see the axial images as well. And
Okay, just 1 second. Give me the mouse. Yeah, don't move the mouse.
okay, sir, I'm not moving.
So this is the axial image.
Okay. So should I scroll it?
Yeah, you scroll it. We are at L5 level right now. Sorry, S1 level.
Okay.
Problem for you? Maybe.
Please. So yes, no, it is scrolling.
Okay.
So
Just
now I'm
concentrate on the thecal sac and tell me what is happening.
okay, sir. Sir, as I move down, so the thecal sac is empty and nerve roots are clumped together. And I would like to confirm this on post-contrast images.
Post-contrast, there was no enhancement.
So they are clumped and especially the air, and giving empty thecal sign in this region. So it is likely.
Here is the CSF. If in empty thecal cell sign, you should see CSF.
So,
where is the CSF?
So this hyperintense all around. So can it represent arachniditis? Clump nerve roots.
So if I just 1 second, if you don't move the mouse, don't move the mouse. Now I have taken over the mouse, so I am showing you. This was a T1 weighted sequence. Now going back to T2. We are at the level of S1.
L5S1.
So this is the sacrum now in your view, and as we come, you can see the thecal sac. So conclusion. What is the conclusion?
Sir,
Hint. I told you the patient has got Cushing's.
so can you show me the T1 once again?
T1.
Yes.
This is the T1.
Okay. So if the patient has Cushing, can it be some hemorrhage into the cord with the...
Right. Thank you. So this is a case of epidural lipomatosis. So what happens in epidural lipomatosis? That basically there is fat, increased fat in the epidural space. Now the causes can be idiopathic or obesity, which is the most common cause. It can be seen, as far as in patients who are on long-term steroids, particularly patients of asthma who are using steroids since ever. and of course Cushing's, etc. 3% of Cushing will have this. Many a times it is asymptomatic, but please remember it can be as symptomatic as spinal stenosis for obvious reasons. And this particular patient was symptomatic, by the way. So what are the learning points here? One is the entity epidural lipomatosis. The eye see what the mind knows. I have not shown you on this T2 weighted sequence. We can see that this is the conus. If you see the nerve root, something is wrong. They are jumbled together. The candidate did well to point that out. They are jumbled together, but the candidate's mind was going into arachnoiditis. Please remember, empty thecal sac sign is a sign where the nerve roots are you don't see them because they are adherent to each other or to the dura, and that is a T2 weighted sign. On a T2 weighted sign, you will see CSF, but there will be nothing else. Now, I did not show you this T1 sagittal. I did not show you, but just to make a point, look at this epidural fat, how much there is fat. But the diagnosis was evident here. Now, if you see only on one cut, which was S1, you could see a bit of CSF and you could see separate nerve roots. As you come up, it becomes very tight. So what is happening is that there is epidural fat surrounding it. And in literature, they say that you will get a Y-shape thecal sac, Y shape. I think this is a Y shape where I'm pointing out. But in our case, this is a Y shape thecal sac, but here the shape becomes even more interesting and interesting. So this was a symptomatic case of epidural lipomatosis. Okay, well
sir.
done. Now, this patient has got 51-year-old right-sided lower motor neuron facial nerve palsy going on for more than 6 months. They had done brain imaging, so this is which is fine. And I want you to, we did a CIS, and I want you to take over and go through this one. I'm interested on the right side only. So can you ask for mouse?
Yes, sir, I'm asking. Okay, sir. So I'm provided with this protocol. I'll scroll from the top to the bottom and here I can appreciate that there is an ultra MR signal intensity area, which is noted on the right side of the CP angle, which is extending into the internal auditory canal, and so it is not scrolling. I don't know. Okay. And the left internal auditory canal is unremarkable. If I compare,
Just concentrate on right side.
yes, I'm just comparing both. So there is something extra sitting here in the right internal auditory canal, which cannot uh, see on the left.
And in relation to the facial nerve, where is the facial
Yes.
nerve? Can you show me the facial nerve?
Yes, sir. I'm trying to locate. So this is the vestibulocochlear nerve, and it is compressing the facial nerve, or I cannot see the. This is the face. This one is the facial nerve, and so it might be arising from the facial nerve. So it can be facial nerve schwannoma or something
What
like
will you like to
meningeal
do
compress.
next? What will you like to do next?
Sir, I would like to review this area upon post-contrast images.
Okay, I've given you post contrast.
Okay, in the post-contrast images, uh, so there is enhancement noted in this area, and so it's a dural, it's broad dural base, so it's likely small meningioma sitting there in the near the internal aortic canal, and it is causing compression of the facial nerve. And I can
Excellent,
also
well done. Okay, we stop there. Now, let me go through this. And audience, if you can concentrate on this, I'm going to teach you facial nerve anatomy. So, this is a meningioma, right? CP angle cistern. I'll go back to this was basically this small meningioma was compressing the facial nerve. And this kind of a case is an exam case, and the examiner will all ask anatomy, what is what, what is what, what is what, and there will be a barrage of questions. And at times they will put in a mouse on something, what is this, what is this, or they will ask you, show me this, show me this, show me this. Now, facial nerve, basically, this is a schematic diagram which tells you very well how it is. It's not an anatomical diagram. So facial nerve, look at this. In the IAM, the vestibulocochlear nerve as well as the facial nerve, they are going into the IAM. The vestibulocochlear has got, vestibular as well as cochlear component, and facial, of course, is slightly different course. Now, part of this course is well seen on CT and part of it is well seen on MR. It arises from the pons, goes in. This portion initially is known as the labyrinthine portion. There is a geniculate ganglion, and from here branches go anteriorly, and then there is a tympanic portion, which is here, which is at the medial wall of the mesotympanum, and then there is a descending portion which goes into the stylomastoid foramen. This is the stylomastoid foramen. And at the stylomastoid foramen, then it goes into the parotid gland and gives the terminal branches. And that is why lesions of the parotid, they can go, there is a concept of perineural spread upstairs, just like in the masticator space, and lesions can go up like this. So this is the anatomy of the facial nerve. On an axial slice, and this is important for MR, if you see here the internal ear, this is cochlea, and this is the vestibule, superior semicircular canal, lateral semicircular canal, correction, superior semicircular canal, and the lateral. And actually, this was the superior, this was the posterior, and this is the lateral. This is the cochlea. Now, if you see one nerve is coming out of the cochlea, this is the cochlear nerve. Two nerves will come out of the vestibule, superior and inferior vestibular nerve. They will join together to form vestibulocochlear nerve, which is 8th nerve. Point to remember. This is the key point to remember, that the facial nerve is sitting just superior to the level of the cochlea. So I repeat that the facial nerve is sitting just superior to the level of the cochlea. And this is the labyrinthine portion, which is well seen on a CT scan, but not well seen on an MR. And this is the anterior geniculate ganglion. From here, it goes posteriorly. This is the tympanic portion. Then it will descend down into the which becomes vertical here. Now, these four nerves are exam, nerves, because examiners have asked these questions that within the IAM, in the lateralmost portion, you will see four nerves. One is the cochlear nerve, one is the facial nerve, then the superior vestibular, inferior vestibular. So two are anterior, two are posterior, and the formula is 7 up, coke down, which is facial, cochlear, superior vestibular, inferior vestibular. And I remember one of my registrars, she got it in her Viva, and the examiner opened this. This is a oblique sagittal scan. Orient yourself, first of all. This is the cerebellum, and you can see four dots. And this is how the Viva started. What is this? What is this? What is this? What is this? So this is the facial. This is the cochlear. This is superior vestibular. This is the inferior vestibular. And of course, on the IAM, I'll go through the anatomy on the case, but I want to show you just quickly the bony anatomy of the labyrinthine portion. So I am just showing you axial CT scan, and we don't have time to go through everything, but just concentrate on this. Now you remember this is the cochlea. I call it the flower because it looks like a flower. And so the cochlear nerve, you can imagine that this is the IAM, and this is the vestibule. And then we have got the lateral semicircular canal and the posterior and the superior, which is this one. Coming back, the key learning point here is as we go superior to the level of cochlea, just concentrate here. As we are going superior, here you are. You can see this thing. This is the facial nerve canal. Now you can stretch your imagination. You can see that the geniculate ganglion will be sitting here. And from here, you can see that the tympanic portion goes backwards. As it reaches back, then it will descend down. Where my mouse is, it is going down. We are going into the parotid gland. Stylomastoid foramen comes, and then you can imagine that the parotid gland is sitting here. So this is the anatomy. And now let's go back to the case. So now here, if you see here what is happening, let me make it bigger. So this is the flower, which is the cochlear nerve, and this is the vestibule, and they are coming here. You can see that this is anterior. So this is the facial nerve, and you can see that it is abutting here. It is maybe displacing it. So this is that meningioma which was causing everything. And anteriorly, another Viva scenario here is that they will ask you the anatomy of the trigeminal nerve. So this is the trigeminal nerve, which is going into the Meckel's cave, and this is the Meckel's cave. So this case also is an anatomy type of a case. Well done, candidate 3, did very well. Now you have got A&E. Just 1 second, this one. Acute abdomen, A&E, 71-year-old. Over to you. Mouse, yes.
Okay, so I'm asking for the. Okay, sir. So I'm provided with the CT scan axial section, and it's. I'll go to the top and then scroll through the whole case. So the first abnormality I can see is that there are mild bilateral pleural effusions are seen, and it's a portovenous phase. Liver is unremarkable, so as the spleen and pancreas and bilateral kidneys. So there are few non-complicated divertically I can see, and in the transverse colon, and then bilateral mild perinephric fat stranding is noted, and there is thickening of the lateral conal fascias is also seen. And scroll down, and there is mesenteric fat stranding noted in the root of the mesentery, and so I would like to take a look on the mesenteric vessels in the arterial phase, but in this phase there is no thrombosis that can be seen in them. And again, I just for this small left-sided inguinal hernia is also noted a protrusion of the omentum, and again there are prominent mesenteric lymph nodes are also seen along the root of the mesentery, giving the sign of mesenteric paniculitis. And now I would take a look at the colon to look for any diverticulitis. I'm scrolling through the images.
So what is your conclusion?
Sir, so there is mesenteric paniculitis with and sir, in the region of the sigmoid colon, I can see that there is extensive fat stranding which is related to the wall of the sigmoid colon. So there is diverticulitis along with the mesenteric paniculitis, resulting in extensive fat stranding, and it can be the cause of acute abdomen in this patient, and also left inguinal hernia, which is non-obstructing, and we'll take another look at the vessels.
Fine. Thank you. Because of time factor, I'm going to take over. Now, sorry, so the main thing is that this patient, this case is diverticulitis, but the key finding there for which I had kept marks was acute inferior mesenteric vein thrombosis, thrombophlebitis. Now, I'm sure it was too busy a scan to pick that up quickly, but the eye see what the mind knows. So when candidate 3, when you said I'm looking at the vessels, I said, wow, he is going to get it, but you just concentrated on arterial vessels. Now the key thing is that if you see here, look at the diverticuli. So there are even if I go here, can you see my screen or you cannot?
Yes, sir, I can see it.
Okay, I'm scrolling through it and you can see the scrolling screen, correct?
Yes, yes, sir, right.
Everybody in the chat, can you see it? No. No or yes?
Sir, I can see it. And your cursor is also moving.
Yes. I think there are yeses there. So, so the point is that if the key point was that this is, look at the descending colon and there are many divertically. As we come here, there are many divertically. And with that, we see a lot of fat stranding. Now, this fat stranding is slightly unusual. There is a bit of nodularity, bit of edema, and you will appreciate, look at the pattern. Now, the colon is, or the sigmoid is sitting here, and look at the pattern. This fat stranding is next to this thing. So what is this? And you can see even here, there is fat stranding. Here is, and even here, you can see fat stranding here. So actually what is happening is that this is the inferior mesenteric vein. And we can see it very well from here onwards. You can see this cord-like is the inferior mesenteric. And just look at my mouse. We are tracing it upwards. It's going superiorly. And then you will actually, it goes superiorly. Here you are. There is a bubble there. You see this?
Yes,
Air,
yes.
air there.
Here inside it, yes,
Yeah.
sir.
And then we can see that it goes, and continues the splenic vein here.
Panic
We can
moments.
see splenic vein and then the portal vein origin. Of course, there is no portal vein free, portal vein gas. So this kind of a case is a good teaching case or learning case to see that what kind of complications can happen with diverticulitis. And management-wise, they will ask you management questions and these because you should be then worried about venous ischemia. Venous ischemia can develop, but the management is usually conservative, heparin, etc. But the same case can be with you with lot of portal vein, and now you can understand that why there can be air in the portal vein. This is a good example. And also, there is a concept of thrombophlebitis. Usually, when there is acute thrombosis in any part of the body, maybe head and neck or the lower limb or whatever, there can be surrounding inflammation. And this is that zone. Acute, then gradually this edema subsides and everything. But key finding even here is look at this. This is away from the colon. And that was a key finding to pick it up. So these kinds of cases can come also as a long case. Okay, then thank you very much, candidate 3. Candidate 4, are you with
Thank you,
us?
sir. Thank you.
Yes, sir. So can you hear me?
4. So what happened is that this is a patient where, let me show you, 61-year-old.
Okay, sir.
61-year-old fall. Okay, just, patient had a few drinks and had a fall in the lounge, banged head on a table. So A&E scan. Over to you.
Okay. So I'm requesting control.
Yes, please. Here you are.
Okay, I'm provided with CT scan plane of the brain axial images, and I'm scrolling through the images, and bilaterals, cerebral hemispheres up till now appear unremarkable, and there is soft tissue thickening is seen in the frontal region, and I'm scrolling through the images, and bilateral globe appear normal, and there is a soft tissue mass lesion is seen in the cellular and supracellular region, which is causing erosion of the anterior and posterior clinoid process and extending into the saphenite sinus as well. And now I'm scrolling through the rest of the images, and
Just concentrate on the finding which you have picked up.
okay.
Very good.
Okay. It is, as I told you, it is extending into the saphenite sinus, and the erosion of the adjacent bone is also noted. And this is likely a case of cellular or supracellular mass lesion, which has a wide differential diagnosis. And I would also like to see the coronal images, or sagittal images, and post-contrast images as well.
Okay, just one
Yeah.
second. What's happening on this?
These are the bone images, and I can see that there is erosion of the posterior aspect of the sphenoid sinus wall, and the mass TN is extending into the sphenoid sinus. And there is also erosion. The clivus is not visualized. I will scroll through the images to I'm unable to scroll.
Okay, can you just stop using the mouse?
Okay.
So what is happening? I'm scrolling for you.
Okay then. Now there is a soft tissue mass lesion is seen in the stela, which is causing the expansion of the stela, and it is, as I previously mentioned, extending into the sphenoid sinus, and no supracellular component is noted. And uh,
Conclusion?
this mass could be macroadenoma. The other possibility could be of metastasis.
What would you like to do next?
I would like to see the post-contrast images as well,
Okay,
to look
fine.
the enhancement pattern and the coronary sinus involvement and the.
Yeah, that's fine. We actually have got an MR, and this is how
Okay.
it looks like.
Okay.
So
It is showing homogeneous post-contrast enhancement. And can I scroll to the image?
yeah, that's fine. Just you have already made the
Uh,
diagnose. We'll stop there.
okay.
Okay then. So that now I want to show you now. So the diagnosis in this case was pituitary adenoma. Pituitary adenoma, as the key point here is that pituitary and surrounding area is an exam favorite area. Remember my words, it's an exam favorite. And they will always show you on an axial. You have to really develop your protocols and things like that to look at this area. And this is a CT brain protocol. And, base of skull orbits, pituitary fossa is there. Pituitary fossa, paracellar, supra. I've shown you quite a few cases today intentionally in one go on CT as well as on MR. So that was the idea. Now this is the anatomy. So this is the pituitary gland, and remember that adenomas are slow growing tumors, so they can cause expansion of the sella. They can go into the sphenoid sinus. They can also erode the clivus or the posterior or anterior clinoid processes, etc., etc. And of course, this is the suprasellar region. So these are normal scans. We'll skip them. Look at this large pituitary adenoma, which where is the sella? Sella is completely gone. Where is the sphenoid sinus? That is also gone. The mass is gone here. The mass has gone superiorly. There is an fluid level in keeping with apoplexy. You can see this high signal on this T1 weighted sequence. On a flare, we can see this fluid level, and you can see that the the internal carotid arteries are sort of encased. There is cavernous sinus invasion also. I'm going to show you 5 cases of pituitary tumor, and these are very good examples, the way they will come in the exam. And the key art is to pick them up on an axial. So from today onwards, it should be your part of the protocol. Keep looking, just like the case which we have seen. This is a large one. And by the way, all of these cases in real life, they were picked up on CT scans. This one is a huge one. And you can see that it is causing erosion here. If I don't have a bone window, but you can see the clivus is also eroded. And then it is going into if you stretch your imagination, the cavernous sinus here, and then it goes suprasellar. This is the posterior clinoid processes. Look at it is part of the component is here and part of the component is here, and this is the midbrain, and there should be nothing there. So part of it is suprasellar. On MR, this is what it was, and you can see how it is causing erosion of the clivus, etc. Now let's go to the second case. Okay, And in this case, you can see how it is encasing the cavernous sinus, internal carotid artery. So there is radiological evidence of cavernous sinus invasion. Let's go to another case. Now, this one is slightly more subtle, but similar to the case which we saw. It is slightly more subtle than the one which we saw which the candidate saw. So there is something happening here. So keep, this is an exam area. Keep looking at, and then if you see, this is definitely abnormal. So you can imagine something is going suprasellar. Something is going suprasellar. And on sagittal, it becomes evident that there is a erosion of the sella here and it goes superiorly. So this is on MR, the same lesion. Another one in which we can see, look here, there is a lesion which is asymmetrical onto this side, onto left side. And then on bone window, this is how it looks like. And on MR, this is how the point is that it was asymmetrical. Look at it. It is very asymmetrical. It is going into the sphenoid sinus inferiorly, but just on one side. So I'm showing you many behaviors which can happen. This one is interesting. This is a suprasellar arachnoid cyst. If you look carefully, uh, this is the posterior clinoid processes. This is the pituitary gland, anterior clinoid process. Look at this. There is on this side, right side, the posterior clinoid process is present. Here it is eroded. Eroded by what? CSF space. This was basically an arachnoid cyst, and please remember, arachnoid cyst can cause erosion of the skull, inner table, etc. So this has caused erosion. And on bone window, you can see that the posterior clinoid process here is present, here it is absent. And then on MR, you can see, I'll show you a T2, I think that will be better. The posterior clinoid process are eroded, and here you are. So this is that arachnoid cyst and how it is causing infundibulum. So the key point is that hypothalamic glioma. Now look at this. This is also a very good exam case. This patient is an old age patient. Look at the CSF spaces. As we go superiorly, now this is the pituitary fossa. Posterior clinoid processes are there. As we going up, this is the infundibulum. And then comes something extra. There should not be something extra. I've shown you quite a few cases of this something extra in front of the midbrain. And this is a favorite in the exam, where observation is the key thing. In front of the midbrain, there should be suprasellar cistern, and something extra is there. You see, still something extra is there. And then comes the third ventricle. So actually, this was, that slice was going through it. So this was a glioma of the hypothalamus. Okay, then. So next case. Okay, so the case, let me quickly go through. The case was well taken. The only thing is that I think you should have asked for a bone window here. You had picked this up, you never asked for a bone window. That before asking for, and the examiners will say before that, you ask for a sagittal, but ask for a bone window and it will give you more information, so which I showed you. And then on sagittal, we can see it here. And then, of course, on MR, we should not waste time on MR because it was all clear. Okay, then. Second last case of the day. Candidate.
Control requested.
Yeah. So this patient is a 29-year-old female, A&E, bilateral flank pain, dysuria, CT KUB, 29 years old. Over to you.
Okay, sir. This is a non-contrast CT scan axial images of the abdominal pelvis. I showed there few hyperdense area seen in the liver, which may represent calcified granulomas. And while scrolling through the images, and there is mild hydronephrosis is seen on the right side. Left kidney appeared normal, and scrolling through the images, and and their urinary bladder is well distended and appear normal. However, I can see few there's a cystic area seen in the right hemipelvis, and large cystic area seen in the right hemipelvis, which is slightly hypodense, and mild ascites or also noted, and the uterus also appear enlarged, and this is likely right hypodense lesion, which is likely ovarian in origin, right ovarian in origin, and which is causing compression on the right ureter and causing right side hydronephrosis. I would further like to investigate this on the post contrast images if available. And
So what is your final conclusion?
so this could be a right ovarian cyst, but it is a high density material is seen within. I would like to take the HU of this lesion.
Yeah,
And
there is a bit of hemorrhage in some of the areas.
okay, so considering all the history, this could be an endometriotic cyst. The possibility could be hemorrhagic right ovarian cyst.
Okay.
And I would.
So I've got a this MR for you.
Okay, these are the MRI images of the same patient. And now I'm scrolling through the images, and there is a large cystic area seen in the right hemipelvis, and there is a low signal intensity also noted in the um, eccentrically located in one of these cysts, and now scrolling through the images, and multiple septations are also noted in this lesion, and there is also another cystic area adjacent to the ovary, which shows internal septation, which is I would also like to review this on the coronal images as well, because this is the cystic area shows tubular configuration with the internal septation, could be fallopian tube with fluid noted in it, and the other rounded lesion with this eccentric low signal T2 signal intensity area may represent endometriotic cyst. And I would like to see the coronal images. So this is
Leave the mouse.
this could.
Leave the mouse. Now this is with you.
These are the coronal images of the. And now there is T2 shading sign seen in the lesion, which is also supporting the diagnosis of endometrioma. And the other lesion which appears hyperintense on T2, and it has a tubular configuration. So this could represent hydrosalpinx. I cannot appreciate right ovary separately. Left ovary is normally visualized. There is also a hyper T2 low signal intensity area seen on the contralateral side, on the left side as well, I guess. Uh, so this could be a case of I'm going through images. I cannot appreciate a right ovary separately. Um, uh, this tubular structure, there is a T2 low signal also noted in it. This could be bilateral enlarged
Anything else you want to
ovary.
see?
Sir, I want to see the post-contrast images to
How would
look
that
for any
happen?
peripheral enhancement, and
This is the post-contrast.
post-contrast images shows there is the peripheral enhancement of that tubular structure, which likely represent uh, uh, helpings, maybe with endometrial uh,
What
adenoma,
is
and at
conclusion?
least
Conclusion.
a right-sided endometriotic cyst with uh, um, pyosalpinx or hematosalpinx.
Okay, just stop.
I'd like to see the
So,
T1.
let me take over. So this is the second last case of the day, and we've got another case to go. This is this is deep pelvic endometriosis, and the point is that on a CT scan, it was fine because there was hydronephrosis and there was cyst and things like that. Now, in a young patient, go for MR. Of course, if there is a role of CT, there will be cases in which there is a role of CT, as in, in your FRCR, in acute abdomen world, in gynae, there are, I think, 3, 4 things which you have to keep in your mind. One is PID, second is ruptured dermoid type of a thing, and this patient could have been but the counter argument is that in a ruptured dermoid, ruptured ectopic, usually you will not see this kind of hydronephrosis. So it was slightly more long-standing. So dermoid or the ruptured dermoid, uh, PID, ectopic, these are the top 4 in the gynae world, and endometriosis, of course. Now, on this MR, the point is that the key sequence, you should not have asked for a coronal. After axial, 2 things you should make sure. One is to confirm hemorrhage, you ask for a fat saturated T1 weighted sequence. So this is not a fat saturated, this is what we call regular, but I think I must have it. Yeah, this is a fat saturated sequence, and the shading which you were referring to, you should have said in the same breath that I would like to confirm it on a T1 weighted sequence. Second thing is, when there is endometriosis, deep pelvic endometriosis, the key thing is that you have to look for other findings, and the best sequence in gynae world is a sagittal. You should have asked for a sagittal. You cannot look at the uterus the way you look at the uterus on sagittal. You can never make it out on a corona. So sagittal, you should have asked for that. Now in sagittal, there are a few pertinent negatives which you must say. Adenomyosis, which is, uh, endometriosis of the junctional zone. You have to rule that out, or it is positive or negative. So also it allows you to go right, and everything else which you have to comment on. One best sequence is a sagittal, because you can see tethered deposits of endometriosis on the rectosigmoid here, and for every finding, I might give you some marks. And you can see that there is, even the posterior portion of the cervix, it is tethered there. Of course, you picked up the hematometra, and on the other side, this is now enhancement. Enhancement can be normal enhancement. Enhancement does not mean that there is infection. There will be cases rarely where there can be secondary infection, and we have got a DWI also. So contrast is only in the world of what we call PID. Otherwise, it's not an important sequence. So this is the DWI, and you can see that there is no abscess or anything. So don't go home with this idea that if you will see this kind of enhancement, you as means that this is infection. Right. So this was for description, but the key is selection of sequences. So sagittal is the best sequence. And then, of course, T1 should have been asked. Last case of the day. Now, what do you think is happening here?
Sir, there is a blooming artifact on the GRE sequence.
Ask for mouse.
Okay. Sir, I already have mouse.
Yeah.
Okay, now I'm going through the images, and there are multiple areas of blooming artifact seen in the cerebellum, brainstem, and the bilateral cerebellar hemisphere, and they are of variable sizes, and involving the basal ganglia as well, and considering these findings, this is there are multiple of variable sizes involving almost whole the brain. So my differentials include, number one, it could be multiple cavernomas. The other possibility could be the amyloidosis, but it is less likely because it there is more involvement of the cortex and the subcortical white matter, and the other could be the hypertensive bleed, and um,
So how can you differentiate between all of these conditions which you have said?
uh,
You meant to say cerebral
multi
amyloid angiopathy, hypertensive
cerebral
encephalopathy, multiple
uh,
cavernoma.
multiple cavernomas. Multiple cavernomas can show
How
a
can
random
you,
distribution.
my question is, how can you, you can ask for other sequences. This is what I'm trying to say.
So I would like to see the T2 weighted images.
T2 weighted sequence. How will that help you? I've got a T2 here for you.
And mm, um, I can look on the T1 weighted images for any um, hemorrhage, and
Okay, leave
on
the
T2,
mouse. Leave the mouse. Leave the mouse. So uh, this, I've got a sagittal T1, but just to make a point, I'm showing you a sagittal T1.
on sagittal T1 appear grossly normal, and there is no evidence of any
What
hemorrhage.
else would you like to see? So let me
Uh,
show you clear. Here you are.
there the flare images shows few mm, low signal intensity areas in the brain stem and the uh, centrum semiovale on the left side as well.
So what is
And
your conclusion then?
so this is likely conclusion could be amyloid angiopathy, and
Okay, we stop there. Thank you. So you see, a very easy case will become a trick case. And that was the idea, the way I showed you. I could have shown you vice versa also. Could have shown you initially a flare and, vice versa, totally vice versa. I'll tell you what it is. This is multiple cavernomas. Now, why is it multiple cavernomas? In cerebral amyloid angiopathy, this kind of finding will have high signal intensity on flare sequence. I did not tell you the history. This is a 53-year-old, and the patient has got headaches, nothing else. So he presented with headaches. In cerebral amyloid angiopathy, hypertensive and cerebral amyloid is usually 60 plus age, and these patients will have what we call white matter changes. So that was a key finding to differentiate between the two. Now, a quick recap about cavernomas or cavernous malformation. In the brain, vascular malformations, malformations with AV shunts, malformations without AV shunts. These are the types, and then cavernous angioma or cavernoma and developmental venous anomaly. These two are very important for the exam. Cavernoma is a favorite in the exam, and there are so many manifestations which can come. Please remember that the radiological features will depend on the size, etc., and they will change. Another very important point to remember is that cavernomas can grow, by the way. They can increase in size and number. And I've got a 2-year follow-up of this scan. I'll show you. So don't think that they are new plastic, but this is very interesting. They can also regress. So this is very interesting. Whenever you see a cavernoma, one of the things which you should ask the examiner that I want to see with contrast, but in the same breath, tell why. Because about 30 to 35% of cavernomas, it all depends which reference you refer to, are associated with developmental venous anomaly. This DVA. This was known as venous malformation before. Now we call it developmental venous anomaly. So tell the examiner that I want to see any associated developmental venous anomaly. This is a cavernoma of the corpus callosum. And the key point is this is what we call popcorn appearance. And key point is that there is a hemosiderin rim with variable signal intensity on T1 weighted sequence. And it sits on the corpus callosum, goes right and left. And you can pick up here 25-year-old, and you can see multiple cavernomas on T2 star. Please remember that there are two susceptibility weighted image sequences which all depends on which department you are working in. And there's a T2 star which is gradient echo, and this is an SWI susceptibility weighted image of Siemens terms. And one key point to remember is that the vessels in the leptomeningeal vessels, they appear low signal. Don't overcall these as anything. In our case, the main thing, cerebral amyloid angiopathy versus this thing, what we call versus cavernoma versus hypertensive.
Hypertensive.
Key thing is that there should not be any high signal intensity foci on white matter. Now, this is another presentation of cavernomas which will come in the exam. Cavernomas the type of case which I have shown you, can you imagine? You could not see anything on flare, on T2, on T1, and the only sequence on which you saw it was susceptibility. But there are other types of cavernomas which can even be seen on a CT scan. And this is one example where there is a cavernoma sitting in the medulla. And this is also edge of the film type of a case. You will only pick it up if you see it very carefully. And this case on an MR gives you this, high signal on T2 star and gives you a popcorn type of appearance on this T2. Now, with that, developmental venous anomaly. Developmental venous anomaly actually is a vein which is drained by multiple small veins. There are two communications. One is with the ventricles and second one is with the cortical veins. These small veins drain into a big vein. I call it the anaconda, and it gives you this Medusa head, which is in Greek mythology, multiple small snakes sitting there. This is from a new reference, 15 to 20% coexisting cavernous malformations. Old references even called it 30 to 35%. Now, so that is why you have to ask for a DVA. Just to give you one scan of a DVA, and this is the type of finding which you will only see if you know what it is. You can see that there is a straight enhancing lesion here, which has got two small snakes here, and this is the larger snake. This is a DVA, and on a conventional venogram, look how it looks. And these are the small Medusa head appearance. And so this is a good example to develop your eyes on. Now, look at this one where there was a cavernoma here, 12-year-old. And when we gave contrast, you can see that there's a vessel which is going out. It doesn't change management, but in the exam, it will give you more marks. So ask for it, but immediately tell the examiner that is to pick up an associated, what we call DVA. Please remember that cavernomas at times can enhance. Usually they do not enhance, but that doesn't change anything. So let me go through your case once again, and then we have come to the end. So this case, I could have simply started it like this. Flare nothing, this nothing. What would you like to see next? Everything nothing. If I would have shown you a DWI, it was interesting. This is a DWI on which you can see a bit of filling defects. So I could have actually taken your Viva on this DWI, and your eyes would have been picking up, restricted diffusion. Actually, there was something else. So very interesting. This finding was visible on DWI to an extent, and very, subtle findings on some of the other sequences, but it was absolutely horrendous on this, innumerable. You can count them. And we have got a scan which is 2 years follow-up scan. This is a 2 years follow-up scan. And even I don't have to put them right and left, but you can see there many of them are increased in size. And the patient was fine. Patient was asymptomatic. Of course, patients can be symptomatic also. So this is a good example of increasing in number and things like that. Okay, candidate 4, thank you very much.
Thank you, sir.
We have gone beyond time. It's a very challenging format to teach this, potpourri. In any case, I hope it was useful. And what we have learned today is I've shown you quite a few cases in which I wanted you to, cellar and supracellar, paracellar, supracellar region, particularly on axial. So intentionally, I had selected quite a few cases in that world. So develop your eyes on axial, on MR, on CT. Remember the words, cellar, paracellar, supracellar. And everything has got its own differential diagnosis. And then think what is going down, what is going up, as in masticator space, etc. Now, next is going to be a learning from mistakes session next week, and we have got a guest speaker, and he will tell you how brilliantly Dr. Gamal he will present how brilliantly he has set up MDT in his department. That will be very good. He will also show you cases. I have already put in the group. About 200 and something of you had um, volunteered that you want to be part of this learning from mistakes group, and we have put up a Google form there to ask for any international presenters. So anybody who wants to present a case, this will be next week. Just like you remember there was we did it a few weeks ago. So anybody who wants to do that, more than happy. We have got places for up to 6 international presenters. The idea is to select a case in which you saw it in your clinical practice. We are not at all interested who reported it, which department you are from. We just want to know your country. So we want to encourage people from various countries to present it. Last time, I think 5 people presented from 3 different countries, and actually 5 more did coordinate. They wanted to, but they could not because of one reason or other. So I think anybody who wants to present a case, there is a group in which you are there, and you just fill up that Google form. Anybody who doesn't know what I'm talking about and want to be a presenter, we will have 7 minutes for each international presenter, and we will make a flyer, and your name and your picture will be on that. So it's a very good chance for you to present internationally. We want to encourage that. We want to change the culture. This is what it is. So anybody of you who does not know what I'm talking about because you have missed the learning from mistakes forum, you can simply today put it in your feedback that I want to do, and our team will coordinate with you. Put in your contact also in the feedback today. Okay, then. Thank you very much. Any questions? Thank you very much. Thank you for your comments. Yes, somebody has said, can adenomas show washout? Yes, is the answers. Even in one of the slides, I had put it as a pitfall. Adenomas do not uh, at times, follow rules. So yes is the answer. Definitely, if you have read it, you have read it correctly. I have seen adenomas which show washout. That's a known pitfall. So cavernoma versus amyloid, amyloid angiopathy, these patients are usually 60 or 60 plus. These patients will have white matter abnormality, small vessel ischemia type of findings. And our case was absolutely normal, every sequence. There was nothing there. I had not told you the clinical. I should have told you the clinical also, 53-year-old headache. But so that is why it was not cerebral amyloid angiopathy. In cerebral amyloid angiopathy, you will see white matter changes. Okay, then thank you very much. By the way, next week I will be traveling, so I will not be attending the Learning from Mistakes Forum myself, but others will be with you, and the guest speaker will be with you. Okay, then, thank you.